So we've now got Kieran O'Flynn talking to us about the use of antibiotics in urology now and the scale of the problem facing us.
Thank you. The year is 1945, December 1945, and this gentleman has travelled to Stockholm and to give a lecture. And in that lecture, he is prescient. He talks about problems in relation to antibiotic use, dosage, and potential resistance, although he didn't necessarily understand much of the issues around how resistance developed. It is, of course, Alexander Fleming in Stockholm to receive his Nobel Prize. And 70 years later, we are now in a position where we have a major problem in relation to antibiotics. And I would suggest to you emerging problems in relation to our practice as well. So what do we know? We know that 25% of people who are prescribed antibiotics don't finish them. We know that we've had a major delay in terms of new antibiotic production, and new antibiotics have been slow in coming online. And we increasingly know, and it's a problem for us in urology, that people who've taken antibiotics in the last 6 months are twice as likely to be resistant. And this is particularly a problem in relation to truss and biopsy. And furthermore, if we were to reduce our unnecessary antibiotic usage, it would potentially have major benefits. So, what is the practice like in urology? Well, at any given time in the spectrum of urology patients, approximately 50 to 60% of our patients will be using antibiotics. Some of it will be for prophylaxis, some of it for proven urinary tract infections, and other times for suspected urinary tract infections. So we heard this morning about extended regimes of antibiotics in stone patients. And if we look, and this is some data from the GPIU study, that our use of antibiotic prophylaxis is quite variable, ranging across Europe in terms of patients having antibiotic prophylaxis for something as simple as a simple cystoscopy, ranging through a number of other procedures. And not all the time are our patients being managed, I would suggest, adequately. We need to recall as well some of the issues around epidemiology. So this is a very old slide, recognizing in fact that many of our patients will have asymptomatic bacteriuria. This is the line for females, and in young children, mid to adolescents, approximately 1 to 2% of girls will have asymptomatic bacteriuria, but that proportion will gradually rise through life. And this is mirrored in men as we gradually get older. But of course, not many of these patients will actually need to be treated. But it is important in terms of our use of antibiotics, because we use prophylaxis in relation to recurrent urinary tract infections, and then it is not unknown for people to get antibiotics in relation to some of these other procedures listed here, and of course in relation to prophylaxis and treatment of infection when the patients are in hospital. So what's the evidence base for this? Well, on the right for these few slides, you will see recommendations coming predominantly from the European Association of Urology. So asymptomatic bacteriuria doesn't cause renal disease or damage. And in terms of patients, we know from RCTs in pediatric populations that if they have asymptomatic bacteriuria and they're treated, the risk of getting an infection in the future, which is resistant, is significantly higher. So that in relation to recurrent urinary tract infections, screening and treatment is not recommended. It may, and this is level 4, so weak evidence, it may be appropriate to eradicate strains that are considered to be the cause of recurrent infections. So should we be using antibiotics in relation to outpatient cystoscopy? Well, this was a large study done by Hare looking at over 2,000 patients. And he came to the conclusion, in fact, that there was no really good evidence that antibiotic usage was necessary, even in patients who had asymptomatic bacteriuria at presentation. With regard to truss, the argument for using antibiotics is quite compelling. We know that following a truss, approximately 1 in 20 of our patients will develop a symptomatic urinary tract infection. That will lead to a hospitalization of approximately 3% of patients, and unfortunately, a proportion of those will succumb to sepsis. So using antibiotics does appear to be hugely important. However, in the Cochrane database and the Cochrane review published in 2011, they identified 19 randomized controlled trials of about 3,500 patients. And although they accepted that use of antibiotics was hugely important, there was no definitive data to support either single dose or prolonged dose of antibiotics. So we should probably be doing less rather than more. What about shockwave lithotripsy, frequently done as an outpatient procedure? Well, once again, there is a meta-analysis and a systematic review done by Liu a number of years ago, showing that in the absence of infection, antibiotic prophylaxis is not necessary. So good quality evidence suggesting that we shouldn't be doing it. And when we are doing it, we should only do it in carefully selected patients. Urodynamics, frequently done in our departments. Total of 9 randomized controlled trials of almost 1,000 patients. As you would expect, a proportion of these patients are going to attend with asymptomatic bacteriuria. And the number needed to treat to prevent bacteriuria was about 12. But this did not necessarily translate into symptomatic infections. So one has to weigh up whether it is appropriate to use antibiotics under those circumstances. But I would suggest, once again, being cautious. Now, you would think that with the change of catheters, which frequently go on either in the community or in our urology units, there would be good evidence to support or not the use of antibiotic prophylaxis. But it ain't so. When NICE looked at the evidence for this, they found that there was one randomized controlled trial looking at the issue. And that was poorly done. So there's a level of evidence of 4 with a great recommendation of C, and that would be that under normal circumstances it is not necessary to give antibiotic prophylaxis. It may be appropriate in those patients who previously had a symptomatic infection or who have a traumatic catheterization. But once again, caution is required. What about catheter nephrostomy replacement? Well, once again, little or no evidence, and this is something that, in fact, the sections might take forward in relation to this, that if we have no evidence to support a practice, why is it that we're using antibiotics? So the level of evidence would suggest at the moment that asymptomatic bacteriuria, where a nephrostomy is in position, may cause problems, and that we should screen and treat the patient appropriately prior to the procedure. And so it goes on, and I'll quickly skip through these couple of slides in relation to wound classes. For clean surgery, no need for antibiotic prophylaxis. So this would be simple scrotal surgery, vasectomy, inguinal surgery. Clean contaminated surgery, single dose prior to surgery. Clean contaminated involving bowel, so to be single dose. How often in our hospitals do we see ourselves, our colleagues, using what we call extended prophylaxis when the evidence base for it is light? The other problem that we have is a failure in terms of managing infection. And this document, which was published in March, is called Start Smart and Then Focus. And it stems from an earlier publication by the Department of Health in 2009, noting that approximately 1/3 of trusts nationally did not have a robust strategy for reviewing antimicrobial prescriptions. And that following publication of the report in 2009, less than 50% of hospitals actually initiated some action, and that there was a correlation between this lack of action and subsequent outcomes. And what we know about the management of sepsis, and in particular urosepsis, is that we need to be highly focused in terms of getting our intervention in early. And that if we delay our time to antibiotics and use them appropriately, there's a greater risk of death. And that risk of death goes up with each passing hour. So that if we get our management correct, we can reduce the relative risk of death with probably an NNT of 5 for all forms of sepsis. And this, in turn, will reduce potentially the risk of death, which with sepsis and organ dysfunction will rise to between 40 and 50% to approximately 20%. And this would have enormous implications not only for our patients, but also in terms of saving money in a cash-strapped NHS. But it would be good practice. So if we're smart and we're getting it right, we're encouraging our juniors to be very proactive, these patients will do better. They will spend less time in critical care, and they will spend less time in hospital. And as I've said to you, there will be an associated cost saving. But more importantly, in the long term, we will save lives. So in my penultimate slide, I'd like to talk about a very unglamorous topic, and that is the issue in relation to catheter-associated infections. Because urinary tract infections associated with catheters are the commonest cause of health-acquired infections or hospital-acquired infections, and 80% of them are due to catheters. And the truth is that we frequently don't know why patients are catheterized in hospital. So it's estimated, using this safety thermometer that many of your trusts will contribute to, that in excess of 20% of patients are catheterized in hospital at any given time, but that the documentation around that is very poor. And as a consequence, patients become unwell and become septic, and it's currently estimated that between 10 and 20 patients will die from each trust in the UK per year. And these are preventable. And if we were to sum up this would mean that we would have an excess number of deaths in the reach of 3,500. So a significant and important problem. So, what can we do better? Well, I would suggest that we need to optimize our antibiotic usage and be very clear about what it is we're trying to do and doing it appropriately. We need to use antibiotic prophylaxis appropriately and not extend it into treatment. We need, for the future, when we've put patients on intravenous antibiotics, to review those when the patient's temperature has settled. So we need to focus and be clear about how long that course of antibiotics is going to last for, and that the patient is on the appropriate medication. We need to engage with antimicrobial stewardship programs in our hospitals. We need to encourage our microbiologists to be on the ward, helping us out and seeking advice. And finally, we need to remove unnecessary catheters. Thank you.